A very good evening, everyone. So, yesterday we had seen quite a few chapters of forensic toxicology, and today we'll be continuing with the rest of the toxicology part, as well as we'll start with the forensic medicine. So, starting with the corrosive poisons over here. So, talking about the corrosive poisons, now what exactly are the corrosive poisons? The ones which are going to corrode the body, okay, corrode the tissue exactly, or you can say eat away the tissues, and that too how? Through direct chemical action, okay, through direct chemical action, okay. So probably what you need to remember is that their action is primarily local, okay, with minimal systemic effects, okay, but there are few organic acids which can be absorbed, and then it can be acting both locally as well as there can be a possibility of a systemic toxicity, but usually they are locally acting ones, okay, like acids, they fall in the hand and it corrodes the area, right, in the same way. But there are few organic acids which you need to remember, they get absorbed, okay, and then a systemic toxicity can develop. Now, coming to the classification, we have strong acids and we have strong alkalis. Now, about strong acids, we have inorganic acids, that is a mineral one, and we have organic acids. So, talking about the inorganic ones, we have sulfuric acid, we have nitric acid, as well as we have hydrochloric acid. But coming to the organic acids, we have carbolic acid, oxalic acid, and salicylic acid, and the formic acid, of course. So these are the strong acids. When we come to the strong alkali, which is a basis actually, the most important ones which you need to remember: hydroxide, like the sodium hydroxide, potassium hydroxide. Then we have the carbonates, that is sodium carbonate and potassium carbonate. And finally we have the anhydrous one, that is the ammonia. Okay, so this is the classification of the corrosive poisons. Remember, strong acids and the strong alkalis. Okay, now coming to how they act. Okay, so basically when we talk about the strong acids, okay, that is the mechanism is, remember, mechanism is coagulation necrosis. Okay, coagulation necrosis. So basically what happens is, when the an acid falls on the tissue, it dehydrates and precipitates the tissue proteins. It dehydrates and precipitates the tissue protein. So because of that, what is going to happen? There is going to be eschar formation, right? And remember what kind of eschar? That is going to be hard, dry eschar, okay, which is a coagulum. Now, this particular eschar is going to limit, it limits a deeper tissue penetration, because one layer is formed. So then a deeper issue that cannot go, right, deeper tissues. Okay, now, so what you need to remember, where exactly it happens. Remember, columnar epithelium of the stomach, that is the area where it is more vulnerable, okay, and because of that, what can happen? There can be gastric and pyloric strictures which is formed, okay? Gastric and pyloric stricture which is formed, you can see over here, a gastric and pyloric stricture. So remember, there is going to be coagulation necrosis, okay, eschar formation. Once this eschar is formed, it will limit the penetration. What about a strong alkali? Now, in case of strong acids, I was telling about coagulation necrosis, right? But when we talk about a strong alkali, it is liquefaction necrosis. Okay, liquefaction necrosis. So what happens? See, basically the alkalis, they saponify the fat and they solubilizes the protein. Because of that, there is going to be a soft, soapy, and gelatinous mass. Just the opposite of what happens in the acids. What happens in the acids? They're going to be hard, dry, and eschar formation. But in case of alkali, what is going to be there? There's going to be soft, soapy, and gelatinous mass. Okay, but as it is soft, sloppy, and gelatinous mass, it will allow a deeper penetration, right? So allows for deep and progressive tissue penetration. That is what you have to remember. Wherein in acids we have a columnar epithelium, but in case of a alkali, we have a squamous epithelium, and that too of the esophagus is more vulnerable. And because of that, we are going to get later complications are esophageal strictures. Okay, esophageal strictures. This is the normally what happens. Now, coming to the characteristic features of sulfuric acid, nitric acid, and the hydrochloric acid. So these falls under which kind of acids? Remember, inorganic mineral acids. So talking about the mineral acids are as such. See, other name of that, what is oil of vitriol, that is about the sulfuric acid. Aquafortis is nothing but the nitric acid. Muriatic acid. Okay, now coming to the synonym, this is viscid and oily. viscid and oily. But remember, when we talk about the hydrochloric acid, they fumes in the air, okay, and nitric acid, the non-fuming one. Appearance also of the sulfuric acid is viscid and oily. And remember, charring is going to be the black corrosion, okay, black corrosion. And fatal dose is around 5 to 10 ml. Okay, and vitriolage, if you remember, acid attack, right? Acid attack, that is a medical legal importance which we need to remember about the sulfuric acid. For acid attack and all, the acid which has been used is sulfuric acid. Now when we talk about nitric acid, it fumes yellow in air, okay, yellow color in air. That is the appearance of it. And there is a xanthoprotic reaction, that is yellow staining again. Now the fatal dose is 10 to 15 ml. And remember, the medical legal importance is that if at all a nitric acid is been used, it is going to stain on the skin or the cloth, okay. They're going to leave a stain on the skin and the cloth, okay. Talking about the hydrochloric acid, brownish corrosion. Black corrosion is sulfuric acid, brownish corrosion is hydrochloric acid. And 15 to 20 ml is the fatal dose, and this is actually used as a cleansing agent. Okay, now we have something called a hydrofluoric acid also, which is used for glass etching. Okay, glass etching. Now remember that whenever there is a fluoride ion over here, this fluoride ion is going to bind with the calcium, and that is going to lead to severe systemic hypocalcemia as well as cardiac arrhythmias. Okay, not only that, they're going to lead to, or they can cause very painful and deep burns. Okay, deep burns that is going to happen in hydrofluoric acid. Coming to the other organic acids, that is a carbolic acid and oxalic acid. See, we know carbolic acid is what? Phenol, right? So it's going to be phenolic and antiseptic odor. That is what is the characteristic smell of it. So what is the action of it? See, its mechanism of action is protoplasmic poison it is, and it penetrates deep. Okay, so one key feature is carboluria. So that means what? Whenever the urine is there, the urine is going to turn olive green. Okay, you can see the color over here, olive green. That too on standing due to oxidation of metabolites. Okay, so this particular urine, when it's kept, it turns olive green. Now why it turns olive green? That is because of the oxidation of the metabolites, like the hydroquinone, pyrocatechol and all that. Now what are you going to get in a post-mortem finding if at all there is a carbolic acid poisoning? So remember, the stomach wall is going to be hardened and leathery. Okay, so we call it to be leather bottle stomach. Very much important, leather bottle stomach. And the corrosions are grayish white. Okay, so one more thing is that carbolic acid can be used as illegal abortifacient by any quacks. Next one about oxalic acid. See, oxalic acid is a colorless crystal. Again, resembles actually the magnesium phosphate. Okay, so action is what? This is local corrosive. Now one more thing, I was just telling that there are few acids that can act, they can get absorbed and then systemic toxicity can come up, right? And that is oxalic acid. So locally corrosive and systemic toxicity, this is what is going to happen. And see, remember that the oxalic acid, right, it precipitates the blood calcium, okay, as insoluble calcium oxalate. So because of that, there is going to be hypocalcemia, like leading to muscle irritability, tetany, and convulsions and shock. Okay, now most important diagnosis is what? They're going to be envelope. You can see over here, right? Envelope shaped calcium oxalate crystals in urine. Envelope shaped calcium oxalate crystals in the urine. This is very much important. Okay, velvety red or blackish stomach mucosa on a post-mortem finding. Important one. Remember, which is the acid which is having local corrosive and systemic toxicity? That is oxalic acid. Remember this. Next one is about the strong alkalis and their features. See, basically alkalis, they are acrid and soapy, that is a taste, and there is going to be liquefaction necrosis, which we have already mentioned, that is it will be soapy, leathery and all that. Because of that, there is going to be deeper penetration, and which is a primary target? Remember, that is the esophagus. Now specific alkalis like sodium or potassium hydroxide. See, the source is drain and oven cleaners. From there we are going to get that. Okay, so most common cause of severe esophageal strictures, that is sodium and potassium hydroxide. And remember that the fatal dose is nearly around just approximately 5 grams. Talking about ammonia, okay, they form irritant gas. Okay, they form the irritant gas. See, liquid solution is spirits of hartshorn. But remember, primary exposure is that, see, primarily inhalation in industrial settings, that is what important. And that is going to lead to severe respiratory irritation, pulmonary edema, and bronchopneumonia. Okay, that is what ammonia is going to do. Next one, coming to the clinical features and diagnosis of you. See, whenever there is an ingestion which happens, there is going to be severe pain, intense pain, burning pain from the mouth to the stomach. Number one, swelling of the lips, chalky white teeth. Okay, chalky white teeth. Then swollen blackish tongue. Dysphagia is going to be there, that is difficult swallowing. Then there is going to be vomiting. Okay, and that too may contain blood or tissue. Respiratory hoarseness, stridor, edema of the glottis, and even risk of asphyxia will be there. And skin dribble marks, that is eschar. Remember acid, right? Eschar on the skin, chin, neck, and the chest. All these are going to be there when we ingest it. Now, how are you going to diagnose it? See, remember that any particular or corrosive substance, it's very crucial for identifying the substance, right? So remember, oral examination, sorry, clinical examination, we're going to do oral examination, oral burns, drooling, respiratory distress are going to be there. Endoscopy, which is the gold standard one, and remember that is done within 24 to 48 hours to assess the injury extent. Okay, but remember, if at all we are suspecting any kind of perforation, do not do it. Next one, do about a radiology, chest x-ray for aspiration, and abdominal x-ray for perforation. Then comes to the lab test. For lab test, you can go for ABG for acidosis, and then electrolytes. Okay, so all that, especially for calcium, for oxalic acid or hydrofluoric acid and all that, you can just go in for. So now let us see what can be done and what cannot be done. See, for let us talk about what can be done. See, airway, we have to give immediate priority for the airway, right? You remember, right? A, B, C, D, right? So airway, breathing, circulation, okay, all that we have to check in, and we have to make sure that everything is proper. And finally, dilution, that means small sips of milk or water has to be given only within 30 minutes of ingestion, and the patient can swallow. Either you can give egg whites, vegetable oils to soothe the mucosa. And pain relief, definitely burning pain is going to be there, and morphine or a pethidine, that is what is there protocol. And further antibiotics, nutritional support, corticosteroids, all that can be done. But what cannot be done is we cannot induce a vomiting, because we're going to re-expose the area with whatever kind of substance we have ingested. Then we are not supposed to neutralize it. That means what? Strong acid-base reactions we shouldn't do, because they are going to produce heat, exothermic they are, and they are going to worsen the burn. Do not use carbonates, okay, because carbonates are going to produce carbon dioxide gas. Okay, and because of that, abdominal distension is going to be there, and stomach distension, and there is going to be perforation. Remember, no gastric lavage. Okay, no gastric lavage, because high risk we can actually go and perforate the damaged esophagus or the stomach. Okay, the only exception for is it can be taken if at all we have had a organic acid like a phenol or oxalic acid, because less severe local damage. Okay, so next about is the postmortem and the medical legal aspects of it. See, postmortem finding, we have already mentioned, there is going to be corrosion marks, dribble marks on the lips, chin. There is going to be staining on the clothing and hands, nitric acid, remember, right? Then there is going to be characteristic odor, phenolic, if at all. Then corrosion of the corrosion of the upper GI. Stomach may be soft, boggy, and perforated, especially if at all the person has had a sulfuric acid. Okay, stomach color, remember, sulfuric acid, black, charring. Then nitric acid is going to be yellow color. Hydrochloric acid is going to be brownish. Phenol is going to be grayish white. See, all this we have already mentioned, right? And what else? See, most cases of the maybe corrosive poisoning, most cases are accidental or homicidal. Sorry, accidental or suicidal. Homicidal is rare. Okay, homicidal is a rare entity. Next is vitriolage. So, talking about vitriolage, that is an act of throwing a concentrated sulfuric acid on a person, and because of that there is going to be a disfigurement. Okay, so that is classified as grievous hurt under section 320 IPC. Okay, remember that. Then we have something called xanthoprotic reaction, right, in nitric acid, if you remember. That is a yellow staining from nitric acid. Okay, now that is important because that is going to help you in identifying the feature on the skin and the clothing. That's a medical legal importance, very much important. Abortifacient, right? I was telling that phenol solutions can be used sometimes illegally to induce criminal abortions by the quacks. Okay, now one more. See, there is a historical note which you did remember that at the time of uh, John George Hay, actually, they used to have a tub of sulfuric acid, okay, wherein they used to dispose the body. That is what we call to be acid bath murderer. Okay, acid bath murderer. Okay, so this was about it. We will go into the next one, and that is asphyxiants. See, talking about asphyxiants, we have a classification. There is simple asphyxiants, we have chemical asphyxiants, irritant asphyxiants, and systemic asphyxiants. So, what exactly is a simple one? That which displaces the oxygen from the inspired air. Okay, for example, the carbon dioxide. Okay, other ones we have nitrogen, methane, and the helium. Chemical means what which interferes with the oxygen transport or cellular utilization. Again, like this, carbon monoxide, cyanides, hydrogen sulfide. We have irritant asphyxiants wherein they are going to damage the respiratory tract lining. And because of that, there is going to be pulmonary edema. There is going to be not only pulmonary edema but also prevents the oxygen exchange, like ammonia, chlorine, phosgene, and the methyl isocyanate. Then we have systemic asphyxiants. Okay, now in this you have to remember is that there is a category for poison affecting the body via specific mechanisms. Okay, with few mechanisms it is going to act, like carbon monoxide, cyanide, hydrogen sulfide, and all that. So let us see about the carbon monoxide. You might have heard that a family had was sleeping and morning they were all dead because carbon monoxide was liberated from the the AC from the AC unit, and the entire family was dead. It had actually come in the news and all. So that was about that is basically about the carbon monoxide poisoning. So silent killer. So let us see. Say whenever there is an incomplete combustion, carbon monoxide is inhaled. It is going to enter into the bloodstream and it is going to form carboxyhemoglobin. Okay, and the end result is the tissue is not going to get oxygen, right, and tissue anoxia. So if you go back to physiology and then read about the oxygen dissociation curve and all that, and there are many factors that can lead to when oxygen has been favored, and then when carbon monoxide is favored, or what happens when carbon monoxide is there, oxygen carbon dioxide is there, and all that. See, basically hemoglobin has a habit to get in contact with the carbon monoxide more than that of the oxygen. So when carbon monoxide is there, we're going to form a carboxyhemoglobin, right, and the end result is tissue anoxia. Okay, so what is the property of carbon monoxide? They are going to be colorless, odorless, and tasteless gas. Okay, and remember they are what? They are product of incomplete combustion. And the sources of carbon monoxide is basically automobile exhaust, fires, faulty heaters, and tobacco smoke. Okay, now what you need to remember is that I was just telling about the carboxy hemoglobin and all that, right? So always remember, just like that, what I said is carbon monoxide has 200 to 300 times more affinity for hemoglobin than that of the oxygen. So even though oxygen is there, hemoglobin is going to get attached to carbon monoxide only. So carboxy hemoglobin is a stable compound that cannot carry oxygen. That is why there is going to be tissue anoxia, right? So what happens is they're going to prevent oxygen delivery to the tissues, causing systemic hypoxia. Okay, so let us see what happens when there is a carbon monoxide poisoning, the symptoms and saturation and all that. So talking about carboxyhemoglobin saturation, if it is 10 to 20 percentage, it is still mild. We are going to get only slight headache, breathlessness, and skin flushes. But if at all, that is going to be 20 to 40 percentage, There is moderate poisoning, we can say, wherein we're going to get throbbing headache, irritability, nausea, vomiting, confusions. Okay, and that means we can think that okay, this person might be drunk or something. But then there's going to be 40 to 60% if it all comes. That means it's a little more severe form, right? So there's going to be severe ataxia, collapse with exertion, syncope, convulsion, and Kind-Stokes respiration, and pink red skin discoloration. Now, if it is more than 60 percentage, that's going to be fatal, in which there's going to be deepening coma, incontinence, weak thready pulse, respiratory arrest, and death. Okay, now if at all there is some 0.04 percentage of carbon monoxide in the air, death is going to occur in 1 hour. If at all it is a little lesser, that is 0.02, then death in 4 hours. But anyhow, death is for sure. Next one, chronic effects and diagnosis. See, at risk groups, who are the people who are at risk? Traffic police, then automobile workers, heavy smokers, these are the ones, because that combust the gas, they're going to come, right? So what are the symptoms? Dull headache, palpitations, memory loss, Parkinsonism, as well as psychosis. See, delayed death can occur, but how it is going to occur? It is going to occur due to neurological damage. Basically, there is going to be necrosis of the basal ganglia. Okay, because of that basal ganglia, we're talking about globus pallidum and putamen exactly. Okay, now this is a very classical finding which you can say about the carbon monoxide poisoning. Okay, next, how we going to diagnose it? Gold standard is the measurement for carboxyhemoglobin level in the blood. Less than 5, normal. Up to 10, it is there in the smokers, but more than that, no. Pulse oximetry, no, not reliable as such, because they cannot differentiate between a oxyhemoglobin and a carboxyhemoglobin and all that. Apart from that, bedside test we can do, that is water test. 1 drop of blood plus 10 ml of water. Okay, then they're going to turn into pink. Normal blood is brownish in color. If it is pink, that is carbon monoxide poisoning. Sodium hydroxide test, that is blood with sodium hydroxide, it is going to turn pink or straw yellow color. Normal blood, again, it would have turned brown in color. ECG, definitely cardiac arrhythmias and all that I was telling, right? So there's going to be STT changes, okay, and there is going to be dysarrhythmias. So how are we going to manage a carbon monoxide poisoning? Remove the patient from the particular area and shift them so that they get a fresh air immediately. 100% oxygen, just give it to them. Okay, because that is going to reduce the half-life of carboxyhemoglobin. Monitor the cardiac and respiratory status. Complete rest. Okay, whatever cerebral edema has occurred, manage it. How are we going to manage it? Head elevation, hyperventilation, and even giving a mannitol, and hyperbaric oxygen therapy. So that that's a specific antidote, we can say. Again, giving oxygen again. Then postmortem findings, again, very much important for your exam point of view. Cherry red discoloration on the skin, mucosa, and viscera. Classic sign. Remember. Then blood, bright red or pink in color. Lungs, pulmonary edema will be there, and fine froth at the nostrils. Brain, again, I was telling about necrosis of the basal ganglia, right? Putamen, the globus pallidum. No, in delayed death. These are the postmortem findings. Next one, coming to the cyanide, which is a rapid one. See, pathophysiology is what? See, whenever there is a hydrogen cyanide inhaled or ingested, they're going to enter the bloodstream. Once it enters the bloodstream, they're going to bind with the iron in the cytochrome C oxidase, and they are going to inhibit the electron transport chain. And so whenever there is a blockage of electron transport chain, they're going to block the aerobic respiration and ATP production, right? So ultimately there is going to be histotoxic anoxia. Okay, that is what happens. So it can be a gas, it can be a liquid, or in a solid form. Classic smell of bitter almond is going to be there. Okay, so where are which are the areas where we're going to get the cyanide? So remember, industrial area, electroplating, fumigation, and in natural, the seeds of apple, apricots, and cherries, they can have cyanide. And burning plastics, wool, silk, all that combustion gases we are going to get. Okay, but remember, the only problem is that oxygen is there in the blood. Okay, oxygen is there in the blood, but we cannot use it. Okay, aerobic respiration is not taking place, but oxygen is there, and that is going to lead to high venous oxygen saturation in case of cyanide. Next one, whatever clinical features, let us see there, whatever is going to happen in cyanide, right, that is going to be very extremely rapid, and especially with inhalation. So there is going to be headache, agitation, confusion, convulsions, coma. Then in case of heart, there is going to be serious. In case that, there is going to be transient hypertension and bradycardia, tachycardia, hypotension, collapse. All these are going to be there, plus transient hyperpnea and dyspnea, and leading to as respiratory arrest. This is going to be there in case of the cyanide poisoning. But remember, smell of bitter almond, very much important. Brick red skin color. Cherry red, we know what is it, but right now brick red skin color, okay, initially, and later cyanosis is going to occur, because we have already mentioned that venous oxygen is going to be very much high, right? So because of that, there's going to be brick red skin color. But later on, cyanosis, then froth at the mouth. Okay. So one more thing which you need to remember, when we go into lab, there's going to be severe metabolic acidosis, and that too with high anion gap and elevated lactate, and blood cyanide levels, they confirm the diagnosis. So there is something called an antidote kit. And what is that? See, immediate care, 100% of oxygen and supportive care is to be given. Okay, but what you need to remember is that start with the amyl nitrate. Okay, amyl nitrate, because amyl nitrate is going to convert the hemoglobin in methemoglobin. Next one, induce further methemoglobin formation by giving sodium nitrate. Next, again, the basic thing is methemoglobin. I'll tell you why it is. Apart from that, again, give sodium thiosulfate. Okay, because this is going to act like a sulfur donor. See, methemoglobin is going to have a higher, see, when hemoglobin and methemoglobin is there, right? Okay, the cyanide is going to act on the, or go and connect to the methemoglobin than the normal hemoglobin. Okay, that is something which you have to remember. So remember that we are going to have a cyanomethemoglobin when we have higher concentration of methemoglobin in the body. That means what? Hemoglobin is there now to act just like to act with the oxygen. Okay, so that is going to be helpful. And apart from that, the enzyme rhodinase, okay, they are going to convert this cyanomethemoglobin to thiocyanate. Now, this thiocyanate is actually a non-toxic one. So after formation of cyanomethemoglobin, we have to give sodium thiosulfate, so that that's going to act as a sulfur donor, and we have a rhodinase enzyme that is going to convert this cyanomethemoglobin into thiocyanate, and that can be excreted through the kidney. This is something which you remember. So what are the three antidote kit? Amyl nitrate, sodium nitrate, and sodium thiosulfate. Okay, sodium thiosulfate. Remember this. So apart from that, carbon dioxide. Okay, see, carbon dioxide, we get it from the fermentation, the wells, silos, mines, and all that. Choke damp one. Then what we have a nickname, that is killer's well or a ghost well. And the mechanism is, it's a simple asphyxiant actually, which displaces the oxygen. Just like carboxy hemoglobin, what happened? Even carbon dioxide is having much more affinity. So hemoglobin is having much more affinity with carbon dioxide than the oxygen. And what happens? What is the postmortem finding? Signs of asphyxia is going to be there. Okay, petechiae, congestion. Next is ammonia. Ammonia we have already actually dealt with, but again, just remember, we have a pungent odor. Okay, and it forms a strong alkali. They are irritant asphyxiants. Okay, irritant asphyxiant, and severe damage to the mucosa on the respiratory tract, eyes, and skin is going to occur. Then methyl isocyanate. Okay, this is which was used in the Bhopal gas tragedy. And this is a potent irritant, highly toxic. There is going to be severe pulmonary edema, okay, acute one. Then delayed neurological effects, multi-organ failure, because we know still in Bhopal gas tragedy, still there are families who are still suffering. Okay, delayed neurological effects are going to be there in them. So now next is little about the war gases, chemical warfare agents. So the first one is lacrimator, in tear gas actually. Okay, that is going to cause eye irritation. Okay, so what's the one example is that chloroacetophenone. Okay, and locust flower, that is the classic thing which you have to remember. Lung irritants like a choking gas. If they are going to damage the alveoli, and not only that, that's going to be leading to damaging the alveoli, leading to pulmonary edema. Okay, the example is phosgene and chlorine. Phosgene is musty hay feature. Next is talking about the vesicants, which is the blister gases. Now, in blister gases, they are going to cause severe, skin blistering. Okay, for example, we have the mustard gas, we have the leviside. Okay, mustard gas, they have a garlicky smell, whereas leviside, geraniums actually, that is the feature. Coming to the nerve gases, that is the pearlescence. Okay, which is going to inhibit the acetylcholinesterase. Okay, because of that, acetylcholine overload is going to be there. Okay, so they are leading to pinpoint pupils, paralysis and all that. So one of the example is sarin and the tabun. Now remember that this nerve gases, okay, they are going to be colorless and odorless. Then we have sternotators, that's a nasal irritants, okay, because they are going to lead to sneezing and vomiting. Diphenyl chlorarcine, okay, that is one of the example for it. And remember, they are the arsenic based compounds. Okay, so that was about the till now we have dealt with corrosive poisons as well as the gases and all that. Okay, now next one we will see with cardiac poisons. See, talking about cardiac poisons as such. Okay, what exactly that means? What that some toxicity is going to happen, and that is going to affect the heart, right? So that is what is a cardiac poison, and what it acts, how it acts either directly on the myocardium or through its nerve supply. Okay, so what is going to happen when there is an action towards the heart? So they are going to disrupt the cardiac rhythm and function. Okay, because of that, there is going to be arrhythmias. There is going to be heart failures and cardiac arrest. Okay, that's something which is going to happen. So remember, they are going to disrupt the cardiac rhythm and the function, leading to arrhythmia, heart failure and cardiac arrest. Okay, but apart from that, there are three important plant-based things which you have to remember. Okay, which are the cardiac poisons. One is the oleander, aconite and nicotine. Okay, so oleander, we know digitalis-like action they are going to have. Aconite, the sweet poison, and nicotine, that is the stimulant and a depressant. So starting with the oleander, okay, you can see the image pictures over here, right? Oleander, okay, they are from the family Apocynaceae. You can remember all parts of the plants are poisonous, especially the seeds and the kernels. Okay, now we have few variety. Nerium odoratum, we have Cerebra Thevacea and Cerebra odolum. Okay, these are the few varieties of oleanders. Okay, common names you see: Nerium odoratum, Cana, white pink oleander; Cerebra Thevacea, that is Pila canner. Okay, Pila canner, that is a yellow oleander basically. Cerebra odolum, that is a dabar. And dhakur, that's a sweet side tree, we can call it to be. See, for the Nerium odoratum, we have white or pink flowers. Narrow leathery leaves are going to be there, whereas the Cerebra Thevacea, there is yellow bell shaped flowers. Okay, you can see this is the yellow bell shaped flowers, and fruit has a triangular nut in that. Whenever we talk about Cerebra odolum, there are the white jasmine like flowers. Okay, fruit resembles an unripe mango. You can see over here, unripe mango. Okay, and what are the active principles of this oleander? Remember, cardiac glycosides. Okay, digitalis like. In case of Nerium, we have nerin, oleandrin and the carabrin. In case of Cerebra, we have thevetin and cerebrin. Okay, cerebrin. Next one, what exactly happens? See, in case of oleander, when we take it, right, ingestion of the glycosides, if we take, okay, there's going to be inhibition of the sodium potassium ATPase pump, and because of that, increased intracellular sodium is going to be there and calcium is going to be there, right? And because of that, increased cardiac contractility is going to occur and vagal tone, and that is going to lead to bradycardia, okay, atrioventricular blocks as well as arrhythmias. Okay, apart from that, they're going to lead to nausea, vomiting, abdominal pain, and it can appear within few hours of ingestion. Okay, bradycardia and weak pulse, very much important to remember. Malignant dysrhythmias, okay, wherein there's going to be, ventricular ectopy is going to be there. Okay. Then supraventricular tachycardia and with AV block. This is a very classic sign of oleander poisoning. Okay. And remember, specific to cerebra, there is something called burning sensation in the mouth and tingling of the mouth. And oleander poison in the late stages, there's going to be drowsiness, coma, convulsion, and cardiovascular collapse. Okay. And remember, hyperkalemia is going to be there, and that is a grave prognostic sign, which is going to be more than 6.6 milliequivalent per liter. Next is aconite. So talking about aconite, that's a sweet poison. Yes, sweet poison. The monk's hood, we know, wolf bane, we know, right? See, Meetha zahar, that is what they call sweet poison, from the family Ranunculaceae. The entire plant is toxic, but the roots are the most potent one. Okay, and they are being used commonly. See, appearance they're going to be like a conical, wrinkled, like a, it's going to resemble a horseradish. Okay, to such a point that, thinking that's a horseradish, we eat it and accident poisoning can happen, but the taste is bittersweet. Active principle, that is ditapine alkaloids. And remember, one more active principle we have is aconitin, okay, which is a highly potent neurotoxin and cardiotoxin. Apart from that, we have aconitin and we have picra-aconitin. Okay. Apart from that, see, whenever we have an ingestion, we take aconitin. Okay, there is going to be persistent activation of the voltage gated sodium channel, which is going to lead to initial stimulation and followed by paralysis. Finally, we're going to get a myocardial, we're going to get neural and muscular depression. Okay, so within the ingestion, 30 to 90 minutes, we are going to get symptoms. What's the classical initial symptom? Tingling and numbness of the lips, mouth, and the tongue that is going to occur. And later on, that is going to spread to the entire body. Apart from that, increased salivation, there's going to be nausea, there's going to be vomiting and diarrhea. Okay, plus palpitation, hypertension, and this is going to follow followed by the fatal arrhythmias, that is ventricular tachyarrhythmias. Muscle weakness is going to be there. The potential paralysis is going to be there. Tremors is going to be there, and convulsions. And in eye, there is going to be hippus. What is hippus? That is alternating pupillary constriction and dilatation. Again, one of the most important features of the aconite. And remember, consciousness is usually preserved until the late stages of aconite poisoning. Next is nicotine. Now over here, in nicotine poison, that is from tobacco plant, we all know, right? Nicotiana tabacco. Okay, primarily the dried leaves and the stems are the one which is toxic. So nicotine, that is a colorless alkaloid, which you have to remember. And what is the mechanism of action? The mechanism of action is biphasic effect. Remember, they're going to act on nicotinic cholinergic receptor. Okay, and that is going to lead to transient CNS and sympathetic stimulation, because of which there is going to be tachycardia and hypertension. Later on, it leads to ganglionic depression. Okay, as well as it is going to lead to neuromuscular blockade, that is paralysis. But remember, primarily metabolism happens in the liver. Okay, primarily in the liver. To its main metabolite, we are going to get carnitine, and that is excreted in the urine. Okay, so in case of nicotine, we have acute poisoning, we have chronic poisoning, as well as we have withdrawal symptoms. So talking about the acute poisoning, is going to be burning in the mouth and the throat, salivation, vomiting is going to occur, initial tachycardia, hypertension, followed by bradycardia, hypotension, and muscle twitching, convulsions, death from respiratory paralysis, that is acute poisoning. Wherein we talk about chronic poisoning with smokers and chewers, that's the tobacco heart, we can say, in which there is going to be chronic cough and pharyngitis. Okay, there is going to be thromboanginitis obliterans is going to be there, amblyopia, that's vision problem, tremors, dermatitis, and even there is going to be lung cancer. Coming to withdrawal symptom, when there is a withdrawal symptom, there is going to be irritability, anxiety, restlessness, headache, dizziness, increased appetite, weight gain, insomnia, fatigue, intense cravings, as well as bowel irregularity. These are in the withdrawal symptoms of nicotine. So these are the spectrum of features of nicotine based on acute poisoning, chronic poisoning, as well as withdrawal symptoms. Okay, so just we'll go through the uh, fatal doses. Okay, medium oleander, 15 gram of the root is more than enough. Fatal period is 24 to 36 hours. Cerebra cerevisiae, that is 8 to 10 seeds are enough, and that to rapidly 3 hours is more than enough. Cerebra odolum, kernel of one fruit, within 1 to 2 days is the fatal period. Aconite, okay, 1 gram of Indian root and 3, or you can say 3 to 5 milligram of aconitin. Average is 6 hours. Nicotine, that is 60 milligram of pure nicotine or 2 gram of tobacco. Okay, minutes to few hours, very rapid disease. So how are we going to manage it? We have to decontaminate it. Then we have to give a supportive care, that's ABC. Antidote we have to give, and systematic treatment. Okay, so how are we going to decontaminate? By activated charcoal and gastric lavage, like what we learned in yesterday's class, right? Okay, so poison specific treatment for oleander, remember, atropine can be given for bradycardia, digoxin can be given, specific, digoxin fab actually for severe toxicity. Okay, and they can correct the hyperkalemia urgently. Then aconite, we do not have a specific antidote, but atropine can be given for vagal inhibition. Okay, anti-arrhythmics can be given, and again maintain the vital by giving an artificial respiration. Nicotine, atropine can be given for excessive salivation, and apart from that, symptomatically treat the seizures and the arrhythmias, and cardiorespiratory support has to be given in these cases. So, talking about the medico legal importance of this. See, for oleander, okay, this can be used for suicide. Okay, because a paste or decoction can be taken, and that is why cerebra odolum is known as a suicide tree. Okay, sometimes what happens, we have mentioned that it looks like a mango shape and all that. So, because accidentally by accidental, poisoning can also happen, because mistaken cerebra fruit we can take it because we think that okay, this is an unripe mango. And abortifacient, that is a local intuition. Then we have aconite, ideal homicidal poisoning, because it is having a sweetish taste and it is potent and rapidly action can be given. Sometimes I mentioned, right, it looks like an edible raw radish. So because of that, accidental ingestion can be done. Suicide is rare because it's going to be very painful. Nicotine, okay, it happens in infanticides. Because sometimes what happens is they apply the extract to the mother's nipple. Okay, infanticide. Malingering, because sometimes what happens, they place a tobacco leaf in armpits to feign a fever. And accidental, again by the children itself, by mistakenly, but ingestion of the cigarettes by accident. So this is what about the cardiac poisons. So next one, we're dealing with the neurotoxic poisons. See, what are neurotoxic poisons? The ones which are harmful and has an adverse effect on the central and peripheral nervous system. Okay, so what they're going to have, they're going to disrupt the normal nerve function. Okay, and because of that, they're going to lead to a wide range of clinical effects, from sedation to convulsions and death. Okay, that is what is going to happen. So let us classify into cerebral poison, we have spinal poisons, and we have peripheral poisons. Cerebral poisons means what? Somniferous one, narcotics, right? They are going to induce sleep and analgesia. So important one, opium and pethidine. Inebriant, that is intoxicants, they can cause excitement and narcosis, like alcohol, ether, barbiturates, organophosphates. Then we have deliriant, they cause delirium and confusion. Example is what? Again, datura, okay, cannabis, cocaine, okay, they are the examples of it. Then we have the spinal poison, like spinal cord, they're going to cause spinal convulsions by affecting the anterior horn cells. Example, Naxomica, strychnine, gelsemium. Then we have peripheral poisons. Okay, they're going to target the motor nerve end plates, like conium, curare. Okay, now a little about opioids. See, dried lactus, latex from the unripe seeds capsules of a poppy plant. Okay, that is Papaver somniferum. Okay, that is the source. What is the active principle behind that? And they are phenanthrene derivatives like morphine, codeine, and thebaine, and all that. Then we have benzyl isoquinoline derivatives like papaverin and the noscapine. Okay, see, papaverin is a smooth muscle relaxant, you just have to remember, and thebaine, which is there, that's a convulsant. Now coming to the classification of opioids, we have opium natural derivatives, we have semi synthetic analogs, and the synthetic analogs. Coming to the opium one, we have many. We have phenanthrene derivatives, morphine, codeine, okay, like whatever we have told till now. We have semi-synthetic analogs, we have, that is heroin, hydromorphone, and the oxycodone. Coming to synthetic analogs, we have again, there are many, right? And we have names like alpha protein, anilidine, and all that. Now, coming to opioid pathophysiology and mechanism of action. See, mechanism is basically opioids that are going to exert their effect by binding to a specific opioid receptor. And where are the receptors? They are the receptors in the CNS, CVS, and the GIT. Okay. So, what exactly happens? See, the mu receptors which are there, okay, they are going to have few subtypes. Okay, and where are they going to be situated? They're located in the cerebral cortex, they're located in the thalamus and the periaqueductal gray area. See, the mu1 which is there, they are going to be accountable for supraspinal analgesia and euphoria. Mu2 accountable for physical dependence, meiosis, spinal analgesia, as well as respiratory depression. Apart from that, gastrointestinal dysmobility is also going to occur. See, whatever these drugs are there, they can be used therapeutically also. Okay, but when it is more in action, that is the time it is problematic. So, classic effects of opioids, they act at this receptor, mu1 actually. Okay, present in the low concentration at birth. Then we have kappa receptors, that too with again subtypes like kappa 1, 2, and 3. Okay, where is the location? That is in the spinal cord. So what happens? Kappa 1 which is there, they are going to lead to meiosis and spinal analgesia. Kappa 2 is linked to psychotomimesis. Then we have and dysphoria, and kappa 3, that is accountable for supraspinal analgesia. Okay, the dimorphine mixed and antagonist and all that is going to be the drugs in this, and they have a sealing effect and may even cause withdrawal. We have delta receptors which is present in the frontal cortex, limbic system, and the olfactory tubercle. Okay, these are going to lead to spinal and supraspinal analgesia. Okay, the endogenous opioid peptides on that. We have sigma receptor. See, sigma receptor is going to lead to hallucinations, dysphoria, tachycardia, hypertension, and they are going to lead to respiratory and vasomotor stimulation. Okay, the phencyclidine, the ketamine, the pentazoxine, and all those are the few examples of those. Coming to acute opioid poisoning. See, the classic triad of opioid overdose, we have coma, CNS depression, respiratory depression, that is slow and shallow breathing, and pinpointed pupils, what we call to be meiosis. Okay, so what happens is that whenever there is an overdose, severe overdose, imagine there is going to be apnea, circulatory collapse, convulsions, and cardiopulmonary arrest and death. But whenever talk about a lesser severe version, there is going to be severe CNS depression, in which we are going to be coma, convulsion, okay, then there's going to be urinary retention, then going to be meiosis, that's a pinpoint pupils, okay, and respiratory depression, wherein there's going to be bradypnea, there's going to be cyanosis, non-cardiogenic pulmonary edema, and cardiovascular depression, wherein there's going to be hypotension. Other signs, there is going to be hypothermia and bradycardia. Apart from that, whenever there is a chronic poisoning, okay, marked by tolerance, psychological dependence, and physical dependence. It is addiction, people who are addicted to morphine. I think in yesterday's class I was telling about that. So what are the clinical signs over here? There's going to be malnutrition, disheveled appearance, needle track marks are going to be there, skin scars, abscesses, behavioral changes, secrecy, anger, outburst, stealing, all that is going to be there in a chronic poisoning. Okay, and what are the medical complications of that? They're going to lead to endocarditis, hepatitis B, HIV, tetanus due to non-sterile injections and all that. But there's something called opioid withdrawal syndrome also, because if at all we stop suddenly, that's abrupt cessation of the drug, suddenly we are going to get a, for example, heroin. Okay, there could be anxiety, yawning, sweating, rhinorrhea, dilated pupils. Okay, for 8 to 10 hours, after which in 1 to 3 hours it's a peak severe anxiety. There will be tremors, okay, piloerection, okay, cold turkey we call it to be, vomiting, diarrhea, muscle spasms, and after 5 to 10 days, slowly and gradually the symptoms is going to become lesser. Okay, now always remember we have to differentiate this particular condition with pontine hemorrhages. Okay, because in pontine hemorrhages also there is going to be pupil pinpoint pupils. Okay, but that is accompanied by hyperpyrexia and hemiplegia. Organophosphate compound poisoning, that also we have to just rule it out. Barbiturate overdose, alcohol intoxications, then all we have to use. Then again ABC, gastric lavage, that is decontamination. Okay, gastric lavage, always remember opioid poisoning we have to do it with potassium permanganate. Okay, specific antidote we have naloxone. Okay, that's a pure opioid antagonist. Okay, that reverses the respiratory depression and coma. And naloxone administration, how are we going to do? Adult for adult, it is 0.4 to 0.8 milligram intravenously, and then repeat twice. Okay. Next is, let us see about the alcohol intoxication. So primarily where it happens, we know it is in the liver, right? Okay, why the zero order kinetics? So we have a clean horizontal flow chart. I'm going to tell you, see, ethanol, which is there, ethanol in the presence of alcohol dehydrogenase, we are going to get acetaldehyde. Acetaldehyde dehydrogenase is going to convert acetaldehyde into acetic acid. Fine. This is the metabolic pathway of it. Now remember, whenever there is going to be a blood alcohol concentration more than 500, okay, there's going to be respiratory paralysis and death of the patient. But let us start from 50 to 100. Euphoria and decreased inhibition. A little more higher, 100 to 150. Delirious, dizzy person. Emotional instability, incoordination. 150 to 200, dazed, mental confusion, staggering gait. 200 to 300, dejected, stupor, slurred speech. 300 to 500, we call it to be dead drunk. Coma, abolished reflexes. Above more than 500, dead. Why dead? Because of respiratory paralysis and death. So how are you going to manage alcohol poisoning and its chronic effects? See, basically, we are supposed to give a respiratory support. Gastric lavage is supposed to be done within 2 hours of ingestion. Keep the patient warm. See, always remember, methyl alcohol, what is the antidote? Ethyl alcohol. Okay? Because of the competitive inhibition. Or even you can give fomepizole. See, hemodialysis in severe methanol and ethyl glycol poisoning can be done. Now coming to chronic alcoholism, what are the features of it or complications? See, in GI, there's going to be gastritis, fatty liver, alcoholic hepatitis, cirrhosis, pancreatitis. But in case of a cardiovascular, there's going to be alcoholic cardiomyopathy, there's going to be hypertension, dysrhythmias. CNS, there is going to be peripheral neuropathy, cerebral degeneration, Wernicke-Korsakoff psychosis. Okay, neuropsychiatric are going to be there, like amnesia, then blackouts are going to occur, then delirium tremens on withdrawal, and even dementia. Apart from that, let us see a little about barbiturates. See, they are the inebriants, right? Sedative ones, because they remember barbiturates are going to bind with the GABA receptors, and because of that, there is going to be increased duration of chloride channel opening. Because of that, there is going to be respiratory depression, barbiturate blisters, and coma. Give supportive care, urinary alkalization has to be done, and hemodialysis. Benzodiazepines, again, that is an inebriant, again binds to GABA receptor, same key mechanism only. But here they are leading to drowsiness, ataxia. Okay, and specific antidote is fumazidine. Organophosphates, again inebriants, that's the insecticides. Here remember that there is a irreversible inhibition of acetylcholinesterase. Okay, there is going to be garlic kerosene order, meiosis. Atropine and oxime, so they are the antidote. Datura, delirium they are. Anticholinergic, they're going to block the muscarinic receptors. Okay, there are going to be 60s, dry skin, diplopia, drowsiness, delirium and all that. And mydriasis. Physostigmine is going to be the antidote for it. So that was about the neurotoxic ones. So let us see the lastly, and that is the domestic poisons. So you're talking about the domestic poisons over here. We have, so in and around household, whatever we get, okay, common poisons, that is the one. So accidental exposure actually, okay, particularly who runs around the house? Children. So children are the people who are going to get it more. So we have hydrocarbons, we have cleaning agents and disinfectants like dishwashing powders, liquids, detergents, that is Dettol, Lysol, then drain cleaners, cosmetic and personal care like nail polish removers, hair dyes, then kitchen and sanitation products like baking soda, mothballs, that is naphthalene balls, fire extinguishers, garden poisons, okay, that is the pesticides and all that, right? Then miscellaneous like rat poisons, paints, glues, all those are being done. Let us talk about the first one, that is hydrocarbon. It's a compound, organic compound, which is going to have a carbon and a hydrogen atom. Correct? And it's most commonly found in fuels, solvents. It's seen in the furniture polishes and industrial product. And poisoning is frequent actually, especially accidental ingestion by the children. So let us see, there are going to be three main types. Aliphatic one, that's kerosene petrol, straight chain compounds they have. Aromatic, in which they have a benzene ring, that's a benzene toluene. Then we have halogenated. The halogen atoms are going to be there, like the carbon tetrachloride. Okay, so let us see about the aliphatic hydrocarbons, first one. Now over here, there are going to be low viscosity and high volatility. Okay, so because of that, high aspiration risk is going to be there. So low molecular weight is going to be there, and high molecular weight. Remember that in comparison to the low molecular weight and high molecular weight, low molecular weight is the one which is going to be highly toxic in nature, like the gases and liquids. So gases like methane, propane, butane, because LPG and all, they're going to act as a asphyxiant. Whereas the liquids which are there, that is the kerosene, petrol, diesel and all that, they're going to act as cerebral poisons, okay, with high aspiration risk. But coming to the high molecular weight, that is a relatively non-toxic one, which is going to be having high viscosity, low volatility, like the Vaseline and all which we use, and paraffin wax. Okay, so which is going to be the highly toxic one. Remember, that is kerosene, petrol, diesel, which is highly toxic. Okay, turpentine is going to be there, that's a paint thinner and remover. Okay, that is also, but least one non-toxic one, that is a paraffin wax and the Vaseline. Okay, which can be used, which is actually used as a medicinal and industrial, right, like a basis and all that. So what exactly happens is that whenever there is an inhalation or ingestion of the low viscosity hydrocarbon like kerosene and all that, they're going to aspiration is into the lung. Okay, and this is most critical and life-threatening effect. That means there is going to be a rapid spread throughout the pulmonary tree, and they're going to disturb the surfactant function. When there is no surfactant, there is going to be alveolar collapse, athletaxis. That means severe chemical pneumonitis is going to be there, and hemorrhagic pulmonary edema. Plus, there is going to be systemic absorption. They are fat soluble, right, and they're going to affect the nervous system. Depression, CNS depression is going to be there, and potential damage to the liver, kidney, and the bone marrow is going to be occurring because of this. Let us see what is the feature of hydrocarbon poisoning. See, there is a characteristic hydrocarbon odor on the breath, cloth, and the vomitus, and in the lungs, which is the most prominent one. Initially, there's going to be coughing, choking, and gasping, but later on, there's going to be cyanosis, bronchospasm, and hypoxia. Severe hemoptysis is going to be there, coughing of blood, pink frothy sputum, okay, because of the hemorrhagic pulmonary edema. CNS, again, they're going to CNS depression like drowsiness, vertigo, dizziness, headache, tremors, convulsions, progression to coma. Toluene inhalation, if it all occurs, the patient is actually going to look like intoxicated. GI burning sensation in the throat, nausea, vomiting, abdominal pain. Chronic poisoning, it is industrial exposure. Skin, that is chronic eczematoid dermatitis, and systemic, that is weakness, anemia, and peripheral numbness. How are you going to manage the kerosene? First of all, is decontamination. Remove all the contaminated clothing. Wash the skin thoroughly with the soap or water. Then prevent absorption. How are we going to prevent? Put liquid paraffin, okay, 250 ml orally, because that is going to dissolve the kerosene and reduce the GI absorption. Again, and activated charcoal. Remember, no gastric lavage. Gastric lavage is contraindicated because high risk of induced vomiting is there, and because of that we can actually aspire it. Then supportive care can be given. It can be IV fluids and all that. So we have, apart from that, aromatic hydrocarbons like benzene, toluene, and xylene. See, benzene, remember, we are going to get vertigo, convulsion, coma. And if it is a chronic one, we are going to get even leukemia and aplastic anemia. What we can do is we can go in for a stomach wash. Toluene, again, we are going to get pulmonary edema, metabolic acidosis. And remember, there is glue sniffing, that is an associated very much important feature of it. Xylene, cardiac arrhythmias, blood dyscrasias, renal and hepatic damage. Okay, and remember, one of the important fatal doses 15 to 20 ml in benzene. Apart from that, the dishwashing powders which we talk about, the irritant and corrosive they can be. Remember, they're going to irritate, lead to irritation of the mouth and the throat and esophagus. Okay. Just try to give milk or water. We are not supposed to be in an empty stomach in that case. Dishwashing liquids, choking, retching, coughing can be there. Give simple fluids. Then household detergents like Dettol, Lysol and all that. Low toxicity, but remember, aspiration is one of the important danger factor. Avoid stomach wash in these cases. Cosmetics, they are non-toxic actually. Generally harmless, but if at all, we have it in a massive quantity, then it is problematic. So reassurance and observation can be given to them. So in this, one of the most important thing which you have to remember is gastric lavage is contraindicated in kerosene. Okay. So now we are going into the forensic medicine as such. A little about the history, let us start with. Afterwards we'll go into the topics as such. See, the Asian foundations, which is very important for us to know, because as the question paper goes off, it had already come in the assistant professor exam in the Kerala Public Service Commissions. So can come in probably in AIPGT also. Okay, so the history of forensic medicine actually in India, it dates back to Indus Valley civilization. Okay, see, whatever ancient foundational text is there. First one is Manusmriti. Okay, now that is in around 3102 BC. Okay, so ancient legal text laying down rules for justice and punishment over here. Then we have the Sushruta Samhita. Okay, a crucial surgical text which was written by Sushruta. And who is Sushruta? The father of surgery. Okay, with forensic applications have been written. Agnivesha Charaka Samhita. Okay, again, foundational Ayurvedic text on the health and medicine with legal implications. Kautilya Arthashastra. Okay, again, a treatise on statecraft, wherein they cover legal and administrative matters, okay, including the forensic inquiry and all that. So over here, during the British period, with the East Indian Company, they introduced modern medical and legal systems, okay, that codified forensic practice in India. There was a medical college established in Calcutta in the year 1835. Okay, after which there is an academic started. Okay, that is in 1845. The first chair in the medical jurisprudence was created. Okay, that too with Dr. C.T.O. Woodford as a professor. Then early practice, that is Dr. Buckley, conducted the first postmortem in Madras for a suspected arsenic poisoning. That too in the year 1663. Remember, the Coroner's Act of 1871 was implemented in Calcutta and Bombay. Apart from that, we have a legal framework, right? We have that is Indian Penal Code, we have CRPC, Criminal Procedure Code, and the Indian Evidence Act. Okay, when was that established? 1860 Indian Penal Code, 1861 Criminal Procedure Code, and 1872 the Indian Evidence Act. Okay, so now over here, the one important name which you have to remember is Dr. Jason P. Modi. Okay, he is hailed as the father of Indian forensic medicine. Dr. Jason P. Modi. Okay, he is the father of Indian forensic medicine, a pioneering figure, okay, who used to manage medical legal cases after India's independence in the year 1947. Okay, now he is the one who has set new standards for crime investigation in the country, and he has authored the first comprehensive Indian textbook on medical jurisprudence and toxicology. Okay, now this is quite available in the libraries and all that. So here and right now today we have forensic pathology, through which we conduct autopsies and all that to need to know the cause of death from the disease or injury. And apart from that, clinical forensic medicine also we have, right, wherein we are going to examine the living individuals, probably the victims of sexual assault or abuse, and then we give a medico legal opinions for that. That is little about the history part. So next one, we are going to deal with a little about the ethical practices in the medical principles of the Indian physicians. So whatever modern medical practices is there, let us see what are the regulations, oaths, declarations and all that. See, talking about the challenge of young doctors and the reality for patient. See, for the doctors, a lack of knowledge about the medical law and ethics, that can actually lead to negligent behavior and accusations of misconduct. Okay, now but in right now in patients, okay, in patients when we talk about, always remember there is a increasing public awareness in the patients, right, regarding the medical care, and because of that the doctors are always in a heightened level of scrutiny, and because of that the doctors are facing lawsuits, irrespective of any actual fault. So now already I have mentioned about Agnivesha Charaka Samhita, Arthashastra Kautilya, and Shushruta Samhita, right? So a little again, just a revision of it. So remember the Agnivesha Charaka Samhita. So that is the one which is going to give the earliest detailed references to medical ethics in India. Okay, and they are the one which established the codes and codes for training and conduct. Then we have the Arthashastra Kautilya. They emphasize that the physicians require written permission from the ruler to practice and could be punished for negligence. Then we have Shushruta Samhita, and we know he is the father of Indian surgery, Shushruta, right? Now they have given qualities and responsibility of the physician on par with the modern ethical laws. Now there is something called Charaka Oath, in which they have mentioned freedom for envy, that is, pray for the welfare of all the living beings, do no harms. Then commitment to the patient care, that is, dedicate yourself day and night to revealing suffering, never abandon a patient. Confidentiality and respect, that is, respect the customs of the patient's household and maintain confidentiality about what is observed. Then unerring professional conduct, avoid sinful behavior, excessive alcohol and association with the criminals. Lastly, building trust. When entering a patient's home, be accompanied by someone known to them to establish the trust. Okay, these are a little about the Charaka Oath. See, not only that, but there are two other things. There's a Hippocratic Oath, which we all know, which we have already told during our graduation. But apart from that, the Declaration of Geneva. The Declaration of Geneva is nothing but a modern restatement of the Hippocratic Oath. Okay, right now, whatever World Medical Association is there, they have prepared this in response to the medical atrocities. So now we have an international code of medical ethics for the doctor's duty, correct? So we need a duty in general, that's professionalism, right? So over here we uphold the highest standards of professional conduct, practice without being influenced by profit motives. And what is profit? What and all is prohibited? Self-advertisement is prohibited. Receiving payments beyond professional fees is also prohibited. Certify only what has been personally verified. That is what they say. Apart from that, duties towards the sick. that is our fundamental duty, right, to preserve and protect the human life. Show complete loyalty and use all available resources. Seek assistance from others when a case is beyond your expertise. Maintain absolute patient confidentiality and provide emergency care as a humanitarian duty. This is very much important. And duties towards each other, medical etiquette. Treat colleagues with respect, okay, you wish to receive. Do not try to lure patients away from your colleagues. Uphold the principles of Declaration of Geneva. These are the International Code of Medical Ethics actually. Apart from this, there are a few other guidelines. See, we have Declaration of Sydney. Okay, now this is done on the determination of death. See, they are going to provide guidelines for determining death, especially for organ transplantation. Then we have Declaration of Tokyo in the year 1975, that is given against torture. Okay, it prohibits physician participation in torture or inhuman treatment. Then Declaration of Helsinki, that is on human research actually. It establishes ethical guidelines for medical research involving human subjects. So now we have an Indian framework, that is the Medical Council of India, IMC, right? Now it is established in the year 1933. Okay, 1933. We have a governing law, that is Indian Medical Council Act, that is 1956. Okay, and remember, this is based on the Declaration of Geneva. And it is to regulate the medical profession by maintaining a register for all the practitioners and establish a code of conduct. Okay, so whatever, every qualified practitioner must agree to and follow this particular code upon whenever we register with the state medical council, right? At that time only we have, it is like we are supposed to follow even the main medical council, like what we have state medical council and the CCH, same thing. So quickly we'll see what are the functions. See, it maintains the Indian medical register, okay, maintains the medical education, okay, and also recognition of foreign medical degrees and any appeal against disciplinary action. Okay, this is quite an important one. There is one more thing, a warning notice and a professional misconduct. See, an Indian Medical Council or any our council also, okay, they can issue warning notices to registered medical practitioners. It will say that, okay, you have done some unethical practice. Okay, but unethical practice, we know that is known as an infamous conduct, right? We'll talk about that later. But right now, remember that whenever there is any kind of warning notice, okay, that is done. But even after a warning notice, still if the person is going to do the misconduct or carry on with it, then there is going to be a penal erasure. Okay, completed professional death sentence, what we call it to be. So remember, a warning notice is not a formal letter or document issued to the offending practitioner. It actually serves as a broader advisory mechanism about what constitutes a misconduct. Say, warning notice, what you have done, this is a misconduct, it should not be done. But even after that, if at all the person continues to do that, then there is a professional death sentence wherein they are being debarred from the council. Okay, we call it to be penal erasure. Our name is removed from there. Yeah, so next one, we were talking about misconduct, right? So we'll directly jump to the professional misconduct. See, professional misconduct involves actions by a doctor that are deemed disgraceful and dishonorable by the peers in the medical field, and that too after an investigation by the state medical council. Okay, so what are the criteria for a professional misconduct? Alcohol, that means attending the patient while under influence. Addiction, prescribing addictive drugs for a non-medical purposes. Illegal abortion, inappropriate relationship with the patients or their family members, that is adultery. Advertising, direct or indirect promotion, and association with any unqualified people or person. These can be considered as misconduct. Okay, professional misconduct. So what are the pitfalls of association and advertising? See, association with unqualified person, like hiring unregistered assistants. Ghost surgery, that means an unqualified person is entering into the OT, okay, or after the patient is anesthetized. That is not proper, right? Then aiding an unqualified person for a specific task, it should not be done. Then advertising, direct advertising, large signage with a fees, discount and all that, not should not be done. Indirect advertising, that's contributing to general publications like expert on except on the public health, or else you can say participating in radio, TV, allowing name on promotional materials and all that. Not should not be done. And then again, canvassing, that is employing touts or agents to attract the patients. Again, all these should not be done again. But remember, it can be done. This advertising process can be done only if at all we are starting a new practice or changing the location of the old one. Okay, or returning from a temporary absence, then they need to know, right? People need to know that I have come back. At that point of time, okay, we can permit this publications and all that. But apart from that, as a daily basis, publicizing ourselves, it is against law. Okay, so apart from the 6 A's what we have told, issuing false certificates for birth, death, illness, vaccination is again medical misconduct. Okay, then criminal convictions like crimes involving moral turpitude like fraud, theft, dichotomy, that is flea spitting. Okay, receiving or giving commissions from colleagues, manufacturers, or chemists. Gross neglect or duty like prolonged failure to perform professional task, or abandoning a patient who is there under your care. Operating a pharmacy, selling medicines or filling prescriptions or from other doctors, should not be. Commercializing a secret medicines, selling treatments based on undisclosed formulas, should not be done. Disparaging the colleagues, that is speaking negatively about your professional fellow professionals. Okay, or engaging in unfair competition along with them. These all are the ones called as professional misconduct. Now coming to professional secrecy. See, professional secrecy means what? It is a confidential information, right, that a doctor acquires about a patient during the treatment. Okay, so you're not supposed to tell it to anyone. No. There is for example, one doctor, he suspected his patient having an illegitimate pregnancy. Okay, he disclosed his suspicion to her brother-in-law, who was providing her a financial support. The support was stopped. Now, who is that particular patient? They sued for slander, and in this particular case, the doctor was found guilty for breaching professional confidentiality. Correct. So this is a little example regarding that. So now, but when can we tell the secret? Professional secrecy, we are not supposed to say, but there are few conditions where we can tell it. Okay, when the silence must be broken. See, privileged communication is a legal protection for information shared between the patient and the doctor. However, this confidentiality is not absolute. Remember, when the patient gives you permission, preferably written, it says that you can share my information. If at all a court is asking you, a judge or magistrate is ordering you to disclose it, that time we have to. Community interest, probably a patient is having a typhoid carrier or is a typhoid carrier, or you can say someone with a STD working in a public place. That point of time, because of the community interest, we have to do it. Criminal activity, because doctor discovers evidence of crime like a murder or rape during an examination, then they have to tell. Employer inquiries, like disclosing only information relevant to an employee's job fitness with the employee's consent. Insurance reports for medical examination, for life insurance purposes and all that, and that time we can do it. Next one, consent in medical practice, very much important. We have two kind of consent. One is implied consent, other one is express consent. Implied and express consent. Okay, now one more thing, any particular surgery which is done without any consent is punishable. Okay, under IPC section 351, IPC section 351, it is punishable. Okay, now two consents which I told about. Implied consent, what is that? See, we assume from a patient's action, patient is coming to you in a consulting room and offering an arm for injection. That itself is a consent, right? Okay, for simple and low risk procedures. Express consent means what? It is not implied. It should be given orally or by written. Okay, orally for minor procedures wherein a third party is there, and written in all the significant diagnostic procedures or surgical operations. We know that in any kind of surgery procedure we get a n number of papers to sit and sign. That's the consent forms. Then rules for valid consent should be free, voluntary, informed, and clear and direct. Person must be at least 12 years of age for examination, and person must be of sound mind and not under fear or threat or intoxication. And this is under this is given as in the IPC section 90. Okay, 90. Next is regarding the informed consent and its acceptable limits. So we know doctrine of informed consent. That is a rule of full disclosure. Okay, wherein this is a written consent which is obtained from the patient, and they are thoroughly informed about the nature of the illness. They are given idea about the nature of the recommended procedure, possible alternatives, and potential consequences and the complications. Okay, but there are few exceptions to the full disclosure. Doctrine of therapeutic privilege, that is what we call to be first one. So physician can withhold information, okay, because if at all that particular information is given to the patient, that can lead to harm to the patient. For example, severe anxiety. A patient going into the surgery is having severe anxiety and then gets into hypertension, problematic, right? So not a patient but a close relative should be told. Doctrine of emergency, that is under IPC section 92, okay, in which a consent is presumed in life threatening situations where the patient is unconscious, critically unwell, or even we can say the patient has not been able to give a consent and there is no guardian at all at that point of time. So that time doctor in a good faith is going to take the chance. Doctrine of loco parentis. There's an emergency involving a child in which the parents are not available at that point of time, and even the person responsible which is there, that particular person, probably in the school something has happened and the teacher or a hostel warden, they have taken the child and they have come, so they can give the information. That is doctrine of loco parentis. So about consent, there are few other things. See, for medical termination of pregnancy, we only require a pregnant woman's consent, right? Provided she is over 18 years of age. Examination of rape victims, remember, a doctor must obtain prior consent from the victim, informing her that the findings will be disclosed in the court. If at all we have a minor victim, the consent should be taken from the relatives. Consent in intoxication cases, remember that. Okay, the consent obtained from an intoxicated person is invalid. So whatever examination findings are there can be only disclosed after the person is sober and provides consent. Then consent in criminal cases under CRPC section 53. Consent is not required if there is a requisition from a police officer. Examination can proceed with mild force if the person is refusing. Okay, and if the criminal is female, we require a supervision of a female doctor. That's it. So the next one we're going to deal with is about India's Transplantation of Human Organs Act 1994. Okay, now in 1994 this particular act was enacted. What was the problem? See, there was an increase in the commercial trade of human organs, right, during 1970s and 1930s. At that point of time, WHO said that okay, we require ethical guidelines for it. So in India we found out a Transplantation of Human Organs Act, THOA, in 1994. Okay, the act came into effect in Feb 4th, 1995, giving legal recognition to the brain dead in India for the first time. So, what is a human organ under the act? See, any particular part of the body composed of tissue that the body cannot replace if it is entirely removed. That is a human organ. So we have two kind of tissues, right? We have regenerative one and we have non-regenerative one. See, parts of the human body that can grow back or reproduce themselves after removal, that is regenerative one. Ones which cannot regenerate, that is non-generative. Correct? Now, regenerative like the blood, the semen, the bone marrow, the skin. But whereas the non-generative tissue and organs like the kidney, the heart, the lung and that of the liver, these are the non-regenerative ones. See, permanent loss for the donor, these comes under the non-generative one. Okay, so let us see living donors, if at all it is there. The adult individuals who provide free and informed consent to donate an organ or a tissue while they are alive. Okay, the act is going to prioritize donations from genetically related individual with specific exceptions. If at all they are from the cadaver, deceased donors. Okay. Now, the individual from whom organs are retrieved after death, that is deceased donors. The act legally recognizes brain stem death, allowing for organ harvesting before beating heart donors. That means before the living people. Fine. Individuals or ventilators whose brain has irreversibly ceased to function, but whose heart and lungs are kept functioning artificially. Okay. So brain stem death, that is the important one. They are the ones which can be taken. So consent, with the consent and authorization, very much important. Who can give the consent? With prior consent, if deceased provide, there are few people, they write it, after my death my body can be, my organs can be donated or something like that. Okay, so that too with two witness and the person in legal possession of the body. Okay, they can authorize after the removal. They can authorize the removal. Then without any prior consent, the person in legal possession may authorize the removal, provided it does not conflict with the wishes of the relatives. If you know, there is a brainstem death confirmation panel. Okay, now there is supposed to be a brainstem death confirmation panel, and wherein there is going to be hospital overseeing a medical practitioner, an independent specialist from that particular approving panel should be there, a neurologist or neurosurgeon should be there, and a treating practitioner of the deceased person should be there. Okay, see, there are special cases like parents can give authority to permit organ removal in minors who are less than 18 years of age. And in case of unclaimed bodies, after 58 hours also, no one has come and told that okay, this is my relative or so and so. In that, the authority is granted. Now, rules of living donation, the near relative path. So there is a primary rule under section 9 clause 1. They say that organs are removed from the living donor can only be transplanted to another person if at all the donor is a near relative of the recipient. Now, what is exactly near relative means? Either a spouse, son, daughter, father, mother, brother or sister. Okay. Now, this particular restriction aims to prevent commercial transaction. Okay, by assuming an altruistic what is the motive within the close family relatives. There is not going to be any altruistic motive for this because it's a relative, right? Okay. Apart from that, we have something called beyond near relatives. That's a donation based on affection. Now, over here, a donor may wish to donate to someone who is not a near relative, probably because of a personal affection or some other special circumstances. Okay, that time it can be permitted. See, such donations are not automatically permitted, but they require prior approval from whom government mandated authorization committee. Okay. So you can see a donor which is there, they're going to submit an application, donor and the recipient both. Then the committee is going to do a thorough investigation, and finally they just want to see the donation is voluntary, and they're not going to get any money for that particular donation. So for all this, we have institutional framework, that is the gatekeepers and all that. Okay, the practitioners, the facilities, everyone, they are well versed with all the processes. I'm not going to deal much about that. But over here, just remember that section 18 which is there. Okay, they are punishment for unauthorized activities, because whenever there's going to be a conduction or assistance in the organ removal or transplantation by an unregistered facility, that is a problematic. When it is there, they can have an imprisonment around 5 years and a fine up to 10,000 rupees. Okay, and even the state medical council can remove the practitioner's name from the register for 2 years, or even can permanently remove it. Section 19 says that punishment for commercial dealings. The payment is definitely not permissible, but if at all it is there, they are going to get minimum 2 years and up to 7 years of imprisonment with a fine of 10,000 to 20,000 rupees. So this was about the organ transplantation. So next one we are going to deal with is about the COPRA, Consumer Protection Act. Okay, a little about it. So Dr. patient relationship is no longer just a fiduciary, it's also a consumer transaction, right? So there are some things which you have to remember. The official name is Consumer Protection Act, which is established in the year December 1986. What is the core objective behind it? To better protect consumer interest by creating a dedicated framework for resolving the grievances outside of traditional, and they remember they're going to be often slow and costly in the civil courts. Okay, the act establishes consumer councils and other authorities to settle disputes effectively. Okay, grievance has been given, the cupra redressal form is there, and then we're going to go there, give a case, and then we're going to get resolved. So 1995, the Supreme Court ruling conclusively placed medical services under cupra, that is in the year 1995. Okay, so in 1992, April 1992, a national commission first rules that medical services are covered by the act. In Feb 1994, a Madras High Court ruling argues that the opposite, saying that okay, patient is not a consumer. But in the year November 1995, November 13th, so the Supreme Court Supreme Court of India definitely settles the matter and upholds the National Commission's decision. So 1992 they had said let the medical services be under the act. 1994 they said no, it is not. But Supreme Court says that okay, let us put under that only. Okay, because patients who have paid for medical service are legally considered consumers, right? And they can file a complaint for poor service. So under the Copra Act, okay, there is a deficiency in the medical services defined as negligence. So deficiency indicates either a fault, imperfection, shortcoming, or inadequacy in the quality, nature, manner of performance, okay, of the medical services which is provided. Okay, and they can actually go in for a case and say that there is a provisional negligence. Okay, so what qualifies a consumer? A person who hires services for payment and they have paid in full, partially, or promised. Includes any beneficiary of those services who has approval of the original person. And crucially, remember that this includes patients whose fees are covered by a medical insurance policy. The service is not considered free. And what does not qualify? See, individuals receiving entirely free service cannot. Okay, so from a hospital or a doctor that does not charge them, they cannot be a consumer. A person who has paid, they only can be. Someone purchasing goods or services from a resale or a commercial purpose. So the rest of the things we'll be seeing in the next class. Till then, go back, read, and then come back. Thank you.